your senior from KMC 1999 batch. Okay, so today's topic is the examination of the newborn. I think you all know that DM neonatology is a super specialization of 3-year course. So it's a tough task for me to put it into a nutshell for the next 40 to 45 minutes. And I also know the practical difficulty of post lunch session. I don't know how many of you are going to have a good sleep like this, baby. Okay. So first of all, I want it to be a interactive session rather than a monotonous speech. Okay.
Okay, ma'am.
Okay. Thank you. So coming to the examination. So what is newborn examination? It's a systematic examination that is both physical and neurological examination of the newborn. So what for we are doing is the main objectives are it provides us an assessment of the infant's well-being, and it is also used to detect any deviation from the normal, and also used to assess the progress of the development of the child. So the first and foremost question is when to examine the baby. That is soon after birth. Soon after means after resuscitation and examination of the vitals of the baby. This is mainly done to rule out any congenital anomalies of the baby, to give counseling to the parents. And one more examination to be done at 24 hours of birth. That during that examination, we usually ask certain questions like the feeding, the passage of the urine and meconium. So for that purpose, we have to examine the baby at 24 hours of birth. And before discharge, usually, so we assess the weight of the baby for any dramatic weight loss, tremendous weight loss for the baby. And also we assess the skin for the jaundice. And follow-up visit, usually we ask the baby to come along with the mummy during the 6th week like that for vaccination. During that visit, usually we check the weight of the baby, assess the weight gain, and to give counseling regarding the feeding of the baby. Am I clear to you?
Yes,
Yes, ma'am.
ma'am.
Okay. So before going on to the examination in detail, so we know certain terminologies, that is definitions. So the babies are classified according to the gestational age into preterm, term, and postterm. That is, the baby born before 37 weeks and between 37 and 42 weeks are designated as a term, and after 42, that's mostly 42 to 44, they are called as post-term babies. And according to the birth weight, the babies are again classified into low birth weight, very low birth weight, and extremely low birth weight. And what is birth weight? The weight of the baby that is measured within 1 hour of life is called birth weight. And according to the gestational age and birth weight, the babies are again classified into small for gestational age, appropriate for gestational age, and large for gestational age. May I know what for these classifications were made? Any volunteers? What for these classifications and what for all these definitions are made? What so silent? Huh? Why so silent?
Ma'am, to assess the gestational age of the baby.
No, I told. So to assess the gestation age, what for we have to assess the gestation age? That is my question.
Each gestational age will require a particular care. So
Yeah, exactly. So that's the correct answer what I need. So what for these classifications are made in the sense, for example, the preterm babies, as you know, all the organ systems are in the stage of development. So they are more prone for respiratory distress syndrome. They find little difficulty in adapt themselves to the extrauterine life. So they need more care than the term babies. At the same time, the small for gestational babies are more prone for for hypoglycemia, hypothermia, and they are also more prone for infections. So for that purpose, we are categorizing the baby into these subgroups. Okay. Then coming to the clinical examination. So whenever the examiner asks you to examine the baby in the examination hall, the first and foremost step is you have to wash your hands and you have to examine the baby with your clean and dry hands. That is the first step. Okay. Next. So the first step, as I told you, we have to check the birth weight and we have to assess the gestational age. How are we going to assess the gestational age? There is one scoring system called New Modified Ballard Score. And there are two components in this scoring system. That is physical maturity and neuromuscular maturity. According to the maturity, the scoring range from -1 to 5. So from that, totally, we come to the conclusion of -10 to 50. Accordingly, the baby is classified into the gestational age of 20 to 44 weeks. So coming to the Ballard scoring, always, I think, may I know which year you all pre-final or final?
Most of us are
Final.
final years, ma'am.
Final year. What?
Yeah.
Mostly final year students are here.
Yeah, ma'am. Yeah.
Okay. So, in a couple of years, all are going to become very good practitioner, no? So, my small suggestion is not only in pediatrics, so in medicine, surgery, whatever, you have to frame your own protocol in examining and coming to the conclusion of diagnosis. So, always go in a systematic manner. So, it is useful for us. So, as I told you, in the gestation age, there are two components. Always go in a stepwise manner. That is general examination, that is appearance of the baby, and examination from head to toe. So the first is posture. So in the picture, I think you are able to make out that the term baby is having an universal flexion as compared to the preterm babies. So this is the scoring that 5 -1 to 5. Okay, then the next one, excuse me. So then comes the skin. So the skin of the preterm is very transparent with visible veins in contrast to the postterm babies, which used to have a cracked, wrinkled, and leathery skin. So that we used to call the postterm baby as a old man look. And the next one, that is lanugo. What is this lanugo? It is an immature, shiny, soft hair that is present not only on the scalp but also on the back and face of the preterm babies. In contrast, the term babies have a shiny strands of hair known as vela hairs. The next one, ears. The term babies have a well-formed ears, and there is something called ear recoil. So what is this? Fold this pinna down. Assess how quickly it returns back to its position. So in case of normal, there is an instant recoil. But in case of preterm, they have a delayed recoiling and the pinna is also not well formed. And for postterm, they have a thick pinna in the cartilage. Then comes the breast. So we have to assess the size of the breast bed in millimeters. The preterm babies usually lack developed breast tissue, and the term babies have a raised to full areola with breast buds that are 3 to 10 millimeters in diameter. Next, this will give a clue to the whether the baby is preterm or term. That is the external genitalia. This is the pictorial representation of the Ballard scoring system. This is the external genitalia, male external genitalia of a term baby. So you are able to make out here the scrotum is pendulous deeply pigmented and with a well-formed rugae, in contrast to the preterm babies which have even undescended testes. A take-home message of today. Yes,
Excuse me, ma'am.
yes, yes.
Ma'am, we can hear you properly now, ma'am.
Now, am I clear?
Ma'am, your voice
Ma'am,
is less,
can you?
ma'am.
Now, da? Is it okay?
It's getting lower also now, ma'am.
I checked, huh? Now, am I clear? Am I audible?
No, ma'am.
No, ma'am, it's low, ma'am.
Extremely sorry for this.
Thank
Okay.
you.
Okay. So, this is the pictorial representation of the Ballard scoring system. So, this is the external genitalia of a term newborn. So, you are able to make out that the skin, the scrotal skin is deeply pigmented with a well-formed rugae, and both the testes are descended. So, today's take-home message here is always the testes are descended in term babies. If the testes are not descended, if the term babies are presenting to yourself with undescended testes, that is always abnormal. You should not wait for the descent of the testes. We can wait for the descent of the testes only for the preterm babies. Why we should not wait in the sense, we have to immediately screen by doing an ultrasound abdomen to detect where the testis is. And whether it is capable of keeping it in position, we have to try. If not, that should be removed because undescended testes, that is the testes in the abnormal positions, are more prone for testicular tumors. So we have to wait for the descent of the testes only for the preterm individuals, not for term individuals. So, and in females, in preterm infants, they are usually have a large labia minora and clitoris. And in term babies, the labia majora is well formed and covers the minora and the clitoris. Thus, the external genitalia plays an important role in assessing the gestational age of the baby. Next one is the plantar surface. We have to look for the creases. The creases are well formed in the term babies. In contrast, the preterm have a very faint red marks rather than creases. So, from the appearance and head to toe examination, we will come to the diagnosis. That is, we will come to assess the gestational age of the baby. Not only this Ballard scoring is used to assess the baby, designate the baby as preterm or term, it is also used to classify the baby into post-term. Okay, and so these are the main criteria. So there is no need for us even the card. So when we were doing our PG, we used to have this card, the miniature of this card, because to score the babies. But this six, we can make it very easily. We can make to conclusion roughly, not the appropriate gestation, that is like preterm, term, and post-term from the 6 parameter itself. And these are all the neuromuscular maturity scoring. That is, these are the components. It is square window, arm recoil, popliteal angle, scarp sign, and one more is there, that is yield to head. Okay. Now coming to this. So now what we have done by the clinical examination, we have checked the weight of the baby, we have assessed the gestational age of the baby, and from there we will classify the baby into term appropriate for gestational age, term small for gestational age, preterm appropriate for gestational age, post-term large for gestational age, like this. And accordingly, we have to give, for example, when the baby is term and appropriate for gestation age, that baby doesn't need any extra care. That babies need only warmth and feeds. So we are classifying the baby for their care only. Then coming to the head to toe examination of the baby. So why head examination of the newborn is very, very important. What makes the head of the newborn is very unique. That is very special. The spontaneal, yes, the spontaneal makes the newborn unique as well as different from others. Okay, so what is the spontaneous? It is a fibrous tissue between the cranial bones. So we should know little anatomy. So the name of the cranial bones, that is frontal, parietal, occipital. So this is the anterior fontanelle and this is the posterior fontanelle. So some of the sutures we should know. This is the metopic suture that is situated between the two anterior cranial, that is frontal bones, and this suture is called coronal suture. This is sagittal and this one is lambdoid. Okay, so next, so the questions, both theory and clinical questions regarding the anterior fontanelle. So what they are going to ask you? So they usually ask the shape, size, and what else? When you get closed, where do you get large fontanelles, and when do you get delayed closure, like that? Any volunteers to answer for all these questions? What? Okay. So, this is anterior fontanelle. It is a rhomboid or diamond-shaped structure, and then it is usually ranges from 1.5 to 3 centimeter. It's 2.5 centimeter, and it is usually measured like this. So, then shape, size, over. When do you get large fontanelles? Always common is common. Always we have to tell the common things first. So any raised intracranial tension, any large head, as in hydrocephalus, Down syndrome, congenital hypothyroidism, we used to have large fontanelles. Okay, so the fontanelles usually get closed at the age of 7 to, it ranges from 7 to 19 months. Okay, delayed closure. Where else you get a delayed closure? Delayed closure, once again, whenever there is a raised intracranial tension, also in syndromes such as Downs and that is always still common is common. And all three trisomies, we use it to have large proteins. That is 13, 18, 21. What is this 13, 18, 21? Anyone? What is this 13, 18, and 21? Anyone?
Edward and Patta.
21?
Down syndrome.
Very good. So Downs is 21, 13, Patawu and 18 is Edward. Then what about the posterior fontanelle? So the posterior fontanelle is a triangular structure, that is the posterior fontanelle is a triangular structure. It is small in size. It's about 0.5 to 1 centimeter, and then it just admits our tip of the little finger. It usually gets closed by 2 months of age. Okay, then the next question. As I told you, where all it is big, where it is small. There is one terminology called craniosynostosis. What is craniosynostosis? The name itself implies its definition. Syn means fusion. Premature fusion of the cranial bones. So the premature fusion of the cranial bones leads to different shapes of the cranium, that is the head. So as I told you, the premature closure of the metopic sutures lead to trigonocephaly, sagittal, yes, Paul, yes. Sagittal lead on to scapulocephaly, coronal lead on to brachycephaly, and lambdoid may lead on to plagiocephaly. Okay, these are all the various abnormal shapes of the skull of the newborn. And this is brachycephaly. This is actually a syndromic baby. This is Apert syndrome. So it is due to the premature closure of the coronal suture leading on to brachycephaly. So an increase in the transverse diameter of the skull. So what is this? I told you the anterior fontanelle. So when you examine clinically, it is usually flushed with the surface. But here, are you able to make out? There is a bulging. So this is the usual asked question, where do you get bulging fontanelle? Once again, when there is a raised intracranial tension due to any intracranial tumors or meningitis, or sometimes in hydrocephalus, we used to get this bulging fontanelles. So, usually when you palpate the head of the newborn, it is flushed with the surface. Okay. Next, the most important point, head circumference. How will you measure the head circumference? It is measured like this. That is the maximum diameter. Occipitofrontal diameter above the eyebrow is measured with the non-stretchable measuring tape. So at birth, it is usually 35 centimeters. So what else you should know? Head circumference is usually more than chest circumference at birth. So this is the serial increase in the size of the head circumference. Whenever during follow-up, when we are measuring the weight and length of the baby, we have to measure the head circumference along with it so as to assess the following condition. What is this? Anyone? What is this? Diagnosis. Hereafter, this is going to be the picture representation only, because otherwise it will be boring when you talk. What's
Ma'am,
this?
microcephaly. Ma'am.
Very good, very good. This is microcephaly. So what is the, you should know as an undergraduate student, they will ask you the definition of microcephaly. Anyone? Microcephaly? When the head circumference is less than 2 standard deviation below the median for its age, sex, and race, it is called as microcephaly. The most common cause for microcephaly are torch infections. Okay. Next, what is this? Opposite of microcephaly. That's macro. So macrocephaly. So once again the definition. When the head circumference is 3 standard deviation more than the normal for its median for its age, sex, and race. Because why I'm telling you again and again race is there is a racial difference of our head. Okay, so this is called macrocephaly. Sometimes it may be familial also, and we have to rule out other causes such as hydrocephalus, Downs, congenital hypothyroidism, and some mucopolysaccharide syndrome. Okay, then okay, this is the chart. As I told you, the serial measurement of weight, height, weight. So pink for girls and blue for boys. And what is this? The common head swellings you come across in our clinical practice. Always in the examination, they will ask these two things. Always the doubt arises only in the examination. What is this and what is this? Anyone?
Caput succeeding.
Very good, very good. This is caput succedaneum. And what is this?
Cephal hematoma.
Very good, very nice. Okay, so always they will ask these questions to you routinely. What is caput succedaneum and what is cephal hematoma? What are the difference between the two? Okay, so when I was UG, we used to tell, apne opposite or reversal, we used to tell. So for these understanding, so this is the picture. Oh, okay. So cap is normal. So caput succedaneum. So this is, what is this? This is subcutaneous collection of the fluid. Subcutaneous collection of the fluid due to the pressure effect. Okay. So as this is a precipiting part, vertex, so they develop this is subcutaneous collection of the fluid. And since this is extra periosteal, it may cross the suture line. Okay, it usually resolves within 2 to 3 days. Just reassurance alone is needed. On the other hand, cephal hematoma. So what is hematoma? Hematoma is the collection of the blood due to any birth injury. So collection, that is subperiosteal collection of the blood. Subperiosteal collection of blood due to birth trauma. Since this is subperiosteal, it is confined to the suture line. It usually doesn't cross the suture line, and it also resolves within 2 to 3 weeks. Okay, so whenever they ask you, you should know the difference between the two. Okay, so these are the common swellings for newborn. And what is this? This is hydrocephalus. Very good. So this is the most important theory question of you. That is neural tooth defect. So a defective closure of the neural tooth usually occurs as early as 14 to 24 weeks of 24 days of gestation itself. It usually presents as a very clinical. Sorry. So it usually presents itself. Am I audible?
Yes, ma'am.
Okay. So it usually presents itself in various clinical forms such as occipital encephalopathy, frontal encephalopathy, meningomyelopathy, and sacrococcygeal ceratoma. And sometimes it may present just as a tuft of hair in this area. That is called spina bifida occulta. Next, coming to the ear. So head is over. So in the ear, the first and foremost point is you should know what is normal set of ears and what is low set ears. So we have to draw an horizontal line. So we have to draw a horizontal imaginary line from the outer canthus of the ear to the external auricle. Am I clear to you?
Yes, ma'am.
We have to draw an imaginary line. Actually, we have to draw this in an upright posture. So for your comfort, I showed the picture like this. So this is the outer canthus. We have to draw an horizontal imaginary line. So 1/3 should be always above this line. If the 1/3 is above, then it is called normal set ears. If the external auricle is below this line, then it is considered to be low set ears. What is this? Anyone? What's this?
Auricular tag.
Very good. So preauricular tag. So what else you have to note? So whenever we are going to see some clinical marker, that is congenital marker, that is going to give us a clue that the child is going to have any syndromes. So preauricular tag is usually associated with some syndromes such as golden heart, treacher choline, like that. But there is always one thing you should keep in mind. So there is no dictate that always, whenever there is a preauricular tag, that baby should have congenital anomaly. There is no dictate like that. In some cases, in 90% of the patients who are having this preauricular tag, they may have normal structure. They don't have congenital anomalies also. But whenever you come across this thing, you should screen the baby for the various syndromes. Next, this is also a preauricular tag. Sometimes there may be a dip alone, the pit-like structure. So sinus alone, that is called preauricular sinus. Okay, so the significance of preauricular sinus is sometimes it may get infected in future. During that time, it may need the complete removal, surgical removal. Then this is malformed ears. that's otherwise known as microtia. It is usually seen in Treacher Collins syndrome. Then coming to the eyes. This is epicanthal fold. And what is this? Anyone?
Congenital cataract.
Noda. This is not cataract.
Macro.
Leucordia.
Yeah, blue eyes. This is congenital glaucoma. Congenital glaucoma, ophthalmos. Okay, this is cataract. Okay, so the commonest cause are torch infusions, cataract, corneal ulceration, corneal opacity, for everything. And you should know about a few. That is, what is hypertelorism? What is hypotelorism? What is normal? So there is something called intercanthal distance. So there is one formula also. We have to measure the ratio of inner canthal to outer canthal distance multiplied by 100 gives. But this is actually clinically we can make out. So hypertelorism, you should know what is hypertelorism, what is normal, and what is hypo. And what is this? Any idea?
Subconjunctival hemorrhage.
Very good. This is subconjunctival hemorrhage. So this is the commonest ocular finding of the newborn. And then it doesn't need any interventions. Just reassurance alone is needed. Sometimes it may also associated with retinal hemorrhages also. So retinal hemorrhage also resolves in due course of time. So reassurance alone is needed. Okay. Then, are you able to make out here what is this? Here, coloboma. This is coloboma, a defect, coloboma of the eyes. So, whenever coloboma, you should know about this syndrome. You should know some syndrome. They will ask you some common syndrome. So, charge. What do you mean by charge? That is C for coloboma, H for heart disease, atresia quinae, retarded growth, genital anomalies, and ear anomalies. Okay, so these are the common ocular problems. There are many more, and whenever, so these are all the ocular features of our well-known syndrome, that is Down syndrome. So, what do you mean by upslanting eyes? There is something called down slanting also. So you have to draw an horizontal line from the inner canthus like this. If the outer canthus is above this line, that is called upslanting mongoloid slant. If it is down, if the outer canthus is below the line, then it is called down slanting anti-mongoloid slant. Okay? Then coming to the beautiful nose. So the most important of nose is quinal atresia. And for this problem, it is usually ruled out in resuscitation itself. Okay, since this is a neonatal emergency, we will rule out this condition in resuscitation itself by passing a nasogastric tube in both nostrils. Okay, then coming to the mouth. Okay, so this is the most common anomalies we come across in the mouth. So cleft lip and cleft palate. So cleft lip we can make out easily, but cleft palate we have to palpate. We have to palpate the palate usually to find the defect. Why we should find the defect reasons? We are more prone for regurgitation of the face. Sometimes it may lead on to aspiration also. So this is a common, you should know some syndromes that is associated with cleft lip and cleft palate. And this is one of it, that is Patau trisomy 30. What is this? Are you able to make out? What's this?
Hutchinson tooth.
Yeah, this is natal tooth. So mostly it is lower central incisor only, and usually it won't interfere with the lactation and all. So if it is unstable, if it is loose only, we have to remove in the fear of aspiration. Otherwise, it is not of much significance. What is this? What is this?
Tongue tie.
Yeah, very good. Tongue tie. A fibrous tissue between the tongue tip of that is attached to the floor of the mouth. If it is very thin and it doesn't affect the speech of the baby in the sense, the speech in the sense, if it is very thin in the sense, we leave it as such. If it forms a notch when the tongue is protruded with a thick fibrous tissue, we have to do surgical incision within 3 months of age to get a better speech. Okay. Now coming to the neck. So usually in the neck we have to look for various swellings. So the commonest swellings are cystic hygroma, branchial cyst, branchial sinus, and branchial fistula. So this is the branchial cyst. And there is one thing called sternomastoid tumor. So the sternomastoid tumor, the tumor is actually a misnomer. It's actually a hematoma of the sternomastoid muscles due to difficult delivery. So it doesn't, reassurance alone is needed with little physiotherapy. Then, so as we are talking about the neck, we should know about the webbed neck. Where do you get this webbed neck? Webbing
Turner
of neck.
syndrome.
Very good. These are all the features of the Turner syndrome. And once again in the chest, what else you have to look in the chest in the sense? In Turner syndrome,
Widely
yeah,
placed nipples.
very good. That's called shield chest. So shield chest with widely spaced nipples. And in general, in the chest, what else we have to do is we have to, as discussed earlier, that the breast size itself will help us to assess the gestational age. We have to look for any supernumerary. It's called polyphilia breast, and sometimes there may be a swelling of the breast. So actually, it is mainly because of the maternal hormones. So that's called mastitis neonatorum. So we advise the parents not to massage that. It usually resolves on its own within 1 or 2 weeks. Okay. Then what else you look for in the chest? That's good. Not more than that. Okay. Then coming to the abdomen. So the most important structure. What is this?
Umbilical cord.
How many arteries and how many veins? Commonly asked question.
2 umbilical arteries, 1 umbilical
Yeah, very good. 2 arteries and 1 vein. So what for? This is single umbilical artery with a single vein. So it is usually associated with some anomalies. So we have to rule out that whenever we come across single umbilical artery. And these two are anterior due to anterior abdominal wall defect, like a caput and cephalohematoma. Sometimes they will ask what is the difference between omphalocele and gastroschisis. So omphalocele, as the name implies, it is the herniation of the contents through the umbilicus. Okay, and this is what is gastroschisis. It is due to the defect of the anterior abdominal wall. It is usually also located on the right side of the umbilical cord, and here it is the herniation of the contents, so it is usually covered by the peritoneum. Both are pediatric surgical emergencies. Let's finish up all students. One second, Bob. Yeah. So then now coming to the external genitalia examination. So this is what called ambiguous genitalia. So ambiguous genitalia, what you should know whenever you are assigning the sex of the baby is, we should know the length of the phallus. Always the length of the phallus should be more than 2.5 centimeter. The size of the clitoris should be less than 1 centimeter. So when you come across microphallus or any fusion of the labioscrapal swelling or clitoromegaly, so we should be very, very cautious in assigning the sex of the baby. Okay. So this is about hypospadias and epispadias. Then this is what? hydrocele. Then coming to the limbs of the babies. So congenital dislocation of the hip. What you should know as an undergraduate. There is one condition called developmental dysplasia of the hip. So, because as you all know that hip joint is a ball and socket joint, because of the developmental dysplasia, the acetabulum, the socket will become narrow. So, the joint, that is the hip joint, become unstable. So, the instability of the joint can be assessed by this two tests. So, you should know what is Barlow's and what is Waterloo is. So, always remember B comes before O. In Barlow's, what we are doing in Barlow's, we are dislocating the hip by adduction and extension. And in autonomy, that is, in the autonomy, we are relocating the dislocated hip. So, by relocation, we are able to appreciate a clunk sound if the hip is dislocated. Is that clear to you?
Yes, ma'am.
So, what is this?
Polydactyl.
Very good. So, always we have to examine the fingers. So, this is polydactyly. So, some syndromes are associated with polydactyly, such as Lawrence Moon-Biddle syndrome. What is this? Look at the little finger.
Clinodactyly.
Very good. Where do you get clinodactyly? Down syndrome. Okay. So in Downs, we used to get this clinodactyly. And what is this?
Syndactyly, ma'am.
Very good. Syn means fusion. Dactyly means fingers. So fusion. This we used to get in as I have already shown you know the Apert syndrome. Yeah. Very good. And what is this defect?
Congenital talipes equinovirus.
Very good. Superb. So this is congenital talipes equinovirus deformity. And what is this?
Rocker bottom foot.
Super. Where do you get rocker bottom foot?
In Edwards.
Very nice. So rocker bottom feet. CTEV is otherwise known as club foot. Okay. So this is due to congenital vertical talus. Okay. This is rocker bottom feet in Edwards syndrome. Then coming to the skin. So what you're able to make out here? What is this?
Bluish discoloration of the palm.
Very bluish discoloration of the sole. Okay, what it is? It's called acroscynosis. Very easy. Okay,
Yes, ma'am.
so bluish discoloration of the skin is known as cyanosis. There are two types of cyanosis: central cyanosis and peripheral cyanosis. Acro in the sense palms and soles. So central cyanosis, whenever you come across central cyanosis, it is always abnormal. It's pathological. So whenever you come across acrocyanosis, it's peripheral cyanosis, that is nothing to worry. Just providing warmth alone may improve the color of the baby. Okay. And what is this?
Erythema toxicum.
Erythema toxicum. Very good. So what is this? Erythema neonatal. This is an yellowish pustule, that is yellowish papule, the erythematous on the erythematous base. So it usually appears on day 1 to 3 and it resolves on its own. It doesn't need any intervention at all. And what is this?
Mongolian spot.
Very good. This is Mongolian spots. These are bluish or black, bluish to black patches that are usually located on the back as well as on the buttock. And it usually resolves on its own, but it takes time. But nothing to worry. What is this?
Harlequin color change.
Very good, very good. This is harlequin color change. So this is mainly because of the autonomic instability that usually occurs immediately after birth. It usually disappears when changing the position of the baby itself. Okay. Next, what is this? Look at the beautiful eyes. What we are able to make out.
Macrocornea, ma'am.
No. Color. Yellow.
Jaundice.
Yeah,
Congenital.
yellow.
Physiological jaundice.
Yeah,
Yes.
physiological or pathological. That is, that's once again the big chapter. So this is a yellowish discoloration. So this is jaundice. When it appears on first day itself, then it is considered to be pathological. Okay, so yellowish discoloration of the sclera, as well as are you able to make out the skin also is yellow in color in this newborn. Okay, then so almost the general examination is over. Any doubts? Shall we move on to the system examination?
Yes, ma'am.
Okay. So in the system examination, what you have to know. So respiratory system, as usual, we have to auscultate. So bilateral air entry compartment. Okay. What in cardiovascular system? So the apical impulse, it is usually situated in the left fourth intercostal space in the left mid-clavicular area. Okay. So we have to look for the apical impulse, and we have, during auscultation, we have to look for any murmurs. According to the murmurs, we have to screen for the particular disease. And what else? I'll tell one clinical scenario. So let us see if anyone knows the diagnosis. So when I'm auscultating, I'm not able to hear the sounds, that is heart sounds on the left side, but it is very much audible on the right side with the absence of breath sounds on the left side, with some gurgling on the right. And on general examination, the abdomen is cupoid with a barrel-shaped chest.
Congenital diaphragmatic hernia.
Oh, may I know your name, doctor?
Rizwana.
Yeah, very good, Rizwana. So for others, this is a condition called congenital diaphragmatic hernia. There is an herniation of the contents mainly into the left side of the chest. So that usually pushed the apical impulse to the right side. So we can come up to the conclusion within 1 minute of auscultation. Okay, so that's why always go in a systematic approach. And that's all about the cardiovascular system. And abdomen, um, we have already talked about the umbilical structures and the abnormality. Usually, normally, the abdomen is soft and the liver is palpable 1 centimeter below the right costal margin. It's normal. And the tip of the spleen is palpable. Sometimes the left pole of the kidney is also palpable. That and all is normal. Okay, this is about the abdomen and nervous system. So nervous system. We are not going to examine like adults. It's like motor, sensory. We shouldn't go like that. So, what is a classic feature of nervous system is by the examination itself. That is the motor system. So, by the cry and activity of the baby, we can somehow come to the conclusion that the motor is normal, and we have to look for any asymmetry. Okay, any asymmetry of this movements, and we have to assess the tone of the baby by just palpating the muscle, and these are the reflexes that gives us clue whether the cranial, that is the central nervous system, is intact. So I think in the development itself, they conveyed about all these reflexes. Am I right? You know what is Moro, what is flipping? Hello?
Yes, ma'am.
Do you want me to explain these reflexes or you know?
Once again.
Can you just explain?
What? Your voice or not clear? No.
Ma'am? Hello, ma'am.
Okay,
Can
I'll
you hear
tell.
me, ma'am?
Just,
Okay, ma'am.
yeah.
Thank you.
Okay. This is what is Moro. So Moro, in this reflex, the head is allowed to fall backward for few centimeters with the child supported in a supine position. Immediately what the baby will do. The baby, so that is what we are doing. We are actually One second. So, I'll clean a picture. So, in the Moro reflex, what we are doing is we are allowing the baby's head to fall backward for just a few seconds. Immediately, the baby will show the reflex like abduction, extension, and opening of the fingers, followed by adduction and flexion. Okay, so these are all used to assess the motor system of the baby. Now, coming to the cranial nerves. Anyone tell me the names of the nerves? I will tell how we will find out whether it is functioning normally or not. Neurons. Any volunteers, please? Cranial nerves. Am I audible? Am I audible? What is the name? Yeah, what is the name of the first cranial nerve?
Olfactory nerve.
Very good. So olfactory nerve. The baby turns towards the breast milk without touch. That shows the olfactory nerve is intact for the baby. And the second nerve?
Optic nerve.
It is usually tested by the pupillary reflex alone. If the pupillary reflex is intact, then the optic nerve is intact. Then coming to the third, fourth, and sixth together. So what are the names of the third, fourth, and sixth nerve?
Oculomotor, trochlear,
Trochlear.
abducens.
Very good. So when there is no ptosis and the extraocular movements are full, that indicates these three nerves are intact. Then for trigeminal, we will check the rooting reflex. If the rooting reflex is normal, then the trigeminal is intact. Then what is the name of the seventh cranial nerve?
Facial nerve.
Facial nerve. What is lower motor neuron type of facial nerve palsy and upper motor neuron type of palsy? Clinically, how will you distinguish these two things? Anyone?
Ma'am, in upper motor neuron palsy, the forehead wrinkles will be present, ma'am.
The
In-
upper half, so in other words, the upper half of the face is paired.
Spad. In lower motor neuron palsy, both ipsilateral half of the
One
face.
half is affected. One half is affected. Why?
Ma'am, because of the bilateral representation in the brain.
Upper motor neuron lesion. Okay.
Yes, ma'am.
Because of the bilateral innervation. So in upper motor neuron palsy, we used to get only deviation of the angle of mouth. There is a differential. Why I am asking now in the sense. So there is one thing called, there is one muscle called DAOM. Depressor angular oris muscle. Okay. So there is a congenital anomaly called the absence of this muscle. In such conditions, there is a deviation of angle of mouth alone that's present in those babies. So we should not mistaken that for seventh nerve palsy. Okay. In newborn, lower motor neuron palsy is more common than the upper motor neuron type. Okay. So lower motor neuron is mainly because of any birth traumas that happens very unusually in forceps deliveries or in breech extractions may lead on to facial nerve palsy. Then what's eighth nerve? May I know the name of eighth nerve?
Vestibulocortical.
Very good. The startled reflex. So Moro itself is one form of startled reflex. That shows, if it is positive in the sense, that shows that the reflex is intact for that the nerve is intact. And for glossopharyngeal and vagus, when the sucking and swallowing, that is the movement. So when sucking and swallowing, that is usually the nervous system is tested at 24 hours of birth. We won't check all these things immediately after birth. Okay. So we have to simply watch for the coordination of sucking and swallowing. If it is normal, then the nerves are intact. May I know the 11th cranial nerve?
Spinal accessory.
Yeah, spinal accessory. We have to just check the flexion of the head. So sternomastoid activity. And the last nerve, it's hypoglossal. So it supplies the tongue muscles. Once again, the tongue coordination is good in the sense we will take the nervous intact. Okay? Any doubt in the examination of the cranial nerves? So we are not going to check as those in the case of others. We are just going to observe. We are just going to observe the activities of the baby, and from the activities we are going to come to the conclusion whether the central nervous system is normal. Any doubts? Shall we move on to the next slide?
Yes, ma'am.
Okay. So, as an undergraduate student, you should know about some common syndromes. So, any idea? This baby? This is the facial features of the Down syndrome. Yeah. So, hypertelorism, low set ears, depressed nasal bridge, mongoloid slant. Okay. So, you should know some common syndromes. And this is Elfin facies. So, Elfin facies you get in which syndrome? Any idea? What?
Williams.
Very good, very good. What is the classic feature of Williams syndrome?
Supravalvular aortic stenosis.
Very good, very good. Great. May I know your name, please?
Sorry, ma'am.
Your name.
Rizwana, ma'am.
Okay. Yeah, coaptation of aorta. One thing I forgot to tell, always you have to palpate the femoral artery on examination. So to rule out the coaptation of aorta. So, but here you used to get supravalvular. And this is the Elfin phases. Okay. Thank you very much.
Thank you, ma'am.
Thank you
Thank
very
you so
much.
much, ma'am.
Thank you, ma'am.
Thank you.
I think, is
Thank
this
you, ma'am.
useful for you? Thank you, guys.
Thank